Part 2. Technical review and the steps of mandibular third molar removal and the complications associated with it. In this technical review, we would look into key steps in the removal of mandibular third molar impactions. On the access side, we do remember that the aim of flap design would be to gain access, to prevent tissue dehiscence, as well as prevent flap necrosis. There are principles in flap design that addresses these goals. A couple that is reiterated in this diagram is we do not cut across vital structures. So in the mandibular posterior region, we stay away from the lingual concavity as well as the medial surface of the jaw. Next, we place our incision on sound bone. And since the mandible has a lateral trajectory, our posterior incision also moves laterally. We avoid lacerating the tissue, especially during reflection, so whenever possible after a mucoperiosteal incision, we start reflecting from the releasing incision located on a untouched mucosa. This not only avoids bony ledges, but it also facilitates tissue reflection because it's easier to reflect tissue here than on a more fibrous, more adherent masticatory mucosa, where when we reflect tissue along the marginal rim incision, remember that the bony ledge on the crest. It is best recommended to start off with the prying motion of your mucoperiosteal elevator, navigating the ledge before you actually start to shift to a push or even a pull motion of your MPEs. Even with a variety of flap designs available to expose the impacted third molar, still all principles have to be followed in terms of flap designs. Again, the goal would be to gain access, prevent dehiscence, and avoid flap necrosis. The aim is to expose impacted tooth, prevent the laceration of tissue, and ensure that a full thickness mucoperiosteal flap is raised. This doesn't only provide access, but a properly laced flap doesn't bleed as much as a split thickness or even a mutilated flap, of course. It is expected that the principle of tissue handling is maintained throughout the third molar surgery. Recommendations on the posterior extent of the flap in this paper suggest a 45-degree tangent in a buccal direction, with the respiratory pushing but not retracting the distal lingual tissue to protect the lingual neurovasculature. Bone reduction and tooth sectioning. The goals of this step would be to expose the impacted tooth underneath bone, if need be, remove any bony undercut, and reach the application depth, as pointed in the diagram. On a personal note, depending on the depth and angulation, I would like to see a landmark like the buccal groove on this benchwork simulated horizontal impacted tooth. Looking at an anatomical landmark helps me determine the extent of my bone removal intraoperatively, since planning on the radiograph is hugely different compared to when I implement them inside the oral cavity. Again, the goals is to expose the impacted tooth, remove any bony undercut, and of course reach the application depth. This will facilitate not only the placement of the application point for instrument, which is your working space, but also create a space for the direction of the delivery of the tooth, your displacement space. We would like to use sharp carbide bursts of adequate size and shape under copious irrigation. Just as with bone removal, there are other instruments that can be used for tooth sectioning as well. We never cut through and through when we leave thinned out portion of the enamel on the lingual and inferior aspect of the impacted tooth. This is to protect the structures beyond them. A diagram shown here in pink on a benchwork project simulating a horizontal impacted tooth shows the extent of tooth removal during sectioning that I'd like or I intend to remove. A reminder, when we section, we leave enough tooth structure to protect underlying anatomy, but this should be thin enough for a controlled fracture of the tooth. We section the tooth to create more space to facilitate removal of the impacted tooth. An example, in a horizontal impacted tooth, we section the crown to create a space for the rest of the tooth to be delivered along its most efficient direction, which is along its long axis. It reminds principles of exodontia. We also section the tooth to reduce the surface area that will be removed at a time, as in the case when you have multiple roots, or as in case of a very bulbous tooth. I do a lot of sectioning in my work. Be reminded, however, that disengagement of the carbide burst, particularly on its weakest point, can happen. And now understanding how this happens will greatly prevent it, but always be prepared and focus on your work. Another possible example that may happen, such as in this case, is that when you lose your follicular space, you sometimes end up having an impacted mandibular third molar that is closely adherent or closely approximating the distal surface of your second molar. At times, this may result into a crown that is located on a sort of undercut that is away from your normal view. Now, in this particular case, I have tried to section the tooth as much as I can from what I see and what I believe to be my initial plan. I broke it off. My actual line of section is dotted down by the red line. My bone reduction dotted down by a blue line. And what eventually happened was when I've tried to break off, section a tooth, I eventually ended up removing the entire tooth itself, leaving the sectioned part behind. Now, how was this possible? Just looking at this particular diagram, the width of the section portion of the tooth was actually the same as the window that I've actually created. Now, initially, before, this gave me an idea that I might have just flicked off or suctioned off that small portion of the tooth. Um, a few hours later, actually a few hours later, following day, when I looked at the patient, I suddenly saw portion of a crown seeming coming out. I took an X-ray, and there where I found the small portion of the tooth that I've actually initially sectioned off. I just flicked it out and confirmed that it has been reduced. This is something that has to be taken into consideration when we remove a tooth. We sometimes think that after sectioning, we would deliver the crown first, but it depends on the amount of space that you have and not the sectioning per se. Now, going to specific bone reduction and tooth sectioning, we would do this discussion on three most common third molar angulations. For the angular impactions that have fused roots, especially if they have very slender bone tooth, bone reduction to reach the application depth might be very adequate enough to retrieve the tooth completely intact. Bone reduction, however, pointed the shaded area, and sectioning, which pointed by the dotted line, even in mesoangular impactions, depending on the degree of impaction, may result to similar sectioning techniques as that with horizontal, particularly when the mesoangular impacted tooth is almost horizontal. Take a look at the diagrams. For horizontal impacted tooth, as with the general concept of bone reduction, it varies depending on the depth and degree of impaction. The more embedded it is in bone, the more reduction it requires to reach application depth and hurdle past the large convexity of the crown. A reminder on sectioning, which is commonly done in horizontal impacted tooth. Its width should be small enough to provide a snug fit for your instrument, to provide enough force for you to break the remaining part of the section tooth. However, a small groove might make it easier to break the tooth section portion, but in class 2 or class 3 impactions, the space created between the section segments might be too small to allow complete delivery of the section, shown here in the diagram. When we section a tooth, think of the line you are creating. What you don't want to do is to create an undercut. Ideally, a diverging section is preferred, but in certain cases the handpiece angulation and the available space might not be in congruence. In these cases, a vertical line of section is better than creating a converging line of section. If, however, the available space of the impacted tooth or its direction of impaction could produce more harm to adjacent structures, then additional sectioning to create smaller portions of the tooth may be warranted. In my personal opinion, as you can see in the clinical photos, cutting away tooth for me is better than cutting more from bone, since the intention is to remove the tooth anyway. For me, there's no paper that tells that removing an impacted tooth in total has better outcomes compared to removing it in sections. True, it is more complicated and would take longer if you section a tooth, but that would be more related to the difficulty of the case and not the outcome of its removal. In distal-angular impactions, one of the issue would be the space needed for the displacement of the tooth. If we follow the direction of the tooth in these cases, the ascending part of the ramus will almost always be an interference. This could be aggravated by the amount of space between the ramus and the distal surface of the last erupted tooth. With enough space, bone removal, shown here as a shaded area, will suffice. If, however, the extent of bone removal is not enough, sectioning the distal portion of the crown, also shown in this clinical photo, may give enough space for its delivery. If both space and root number and morphology would be an issue, initially creating a space on the coronal aspect of the tooth, then sectioning of the tooth roots could also be done. As what has been mentioned, sectioning the tooth should be made to facilitate the removal of the impacted tooth. Remember, it is more difficult to remove the tooth. It is more efficient, rather, to remove the tooth following one, its long axis, and second, the root curvature. In cases of impacted tooth, the curvature of the root might dictate the need for sectioning more than its angulation, such as this clinical case wherein a mesioangular impacted tooth with fused roots that appears to be slender radiographically. However, it had an apex that had a lingual curvature. This necessitates the need to section the crown to allow me to remove the root towards a lingual direction. Take a closer look at this diagram. Now, I personally feel that a properly created space with or without a need for tooth sectioning is the most important part of the procedure. Having properly planned and done these things should in most cases allow the smooth elevation and delivery of the tooth. A small insight into the surgeon's mind. Always be reminded that there is no absolute certainty in surgery, regardless whether it's a major or a minor case. The best surgeons will always understand the idea, and that's why good surgeons always have a redundant backup plan. That is a backup plan for a backup plan for a backup plan. Now, points during the delivery of the tooth are the following. The application point reached during bone removal is for your instrument. This is your working space. Supporting the adjacent tooth not only resists its unnecessary displacement, but give you a tactile sense of the movement of the impacted tooth. Always have in mind that the direction of tooth delivery is always related to the movement and elevator mechanics that you will use. Move your instrument to one direction, the tooth moves in that same direction. Go over the previous slide on root curvature if need be. A personal insight. Although retrieving a fractured curved root, such as shown here, might be very rewarding for a clinician, surgeon. However, I would rather not have the need to retrieve any root fractures. Needless to say, I would always try to prevent it from happening. Managing these complications is a whole different thing on its own. And although you should be prepared to handle these complications, we always pray that this would not happen at all. When we retrieve section segments, we normally start from the closest to the bony window that's created. Another consideration I'd like to include and remind is that in case there is a limited space for the retrieval of the crown, further sectioning of the crown should be considered. When we retrieve the rest of the tooth, again, the bony window created should be bigger or at least approximates the size of the remaining tooth. Options when this happens are shown here in diagram. A technique wherein I split the root is also shown in this clinical video. Personal insight, I'd consider to section the tooth first before extending my bone reduction. That's my tooth versus bone concept. After retrieval, debridement is performed, which includes saline irrigation. Once bleeding is controlled, we then suture the incisions. After reducing the sharp edges with a bone file, if it's needed, debridement is done. We remove large debris by picking them up and then copious saline irrigation. For me, that means 6 to 10 flushes of a 10 milliliter syringe. What we often forget is that the base of the flap is oftentimes filled with tooth or bone shavings or small debris, and this may account for the inflammatory reactions we see after the procedure, days after. Best way to prevent this is to properly irrigate the base of the flap. Again, for me, this would be 6 to 10 times of your 10 milliliter syringe or roughly 60 to 100 mLs of irrigation. Questions on what do we do with the tissue taken out? For me, my personal insight is that when it is suggestive of a pathology or it appears very suspicious, then I'll subject this tissue for histopathologic review. Now, more than just for record-keeping purposes, verifying all the retrieved components and recreating the tooth before closing the case is essential to ensure that you have not left any part of the impacted tooth behind. As a personal insight, in the unlikely event that a segment of a tooth fly out during retrieval or if it fell to the floor, inform the circulating to record that a part has fallen off. And, if possible, retrieve it for a validation at a later time when it may be possible. Now, there are a number of possible outcomes whenever we remove impacted mandibular third molars. I will just discuss what I consider a common issue and pass by some uncommon ones just to remind that they do exist. In this early 2000 paper, we can see concepts that may affect outcome of our procedure. In this paper, majority of the relationship they saw in a Jordanian population of the inferior dental canal and the tooth root show that most of it are radiographically superimposed, showing about 15% have true relationship between the tooth roots and the IDC. This paper also noted that majority of the impacted third molars that are bilateral, means both sides have impacted mandibular third molars, they have identical positional relationships. For the concept from this paper that we might consider is a possible significant association between the age group and the true relationship of the inferior dental canal and the impacted tooth roots. Another thing to consider from their data is the appearance of notching, grooving, and those directly adjacent to the IDC are found from those vertical impactions, while perforations appeared although less than a percent in their data among horizontal, mesioangular, and distangular cases. Be still critical, however. Although these are significant findings, it didn't account for other variables like the amount of space available in these cases. Also to consider are the anatomical variances that each racial, ethnic group may have. Needless to say, this data still provides valuable information regarding the prognosis of our procedure. This boils to the inherent complication associated with mandibular third molar removal, which is the inferior alveolar nerve injury. A widely available data shows the possibility of IAN injury. This could be again explained by the data provided in the study previously shown. An insight on a personal case. Take a look at the shadow on the mesial root superimposing the IAC, inferior alveolar canal. And then you see a more radiodense mesial root as it goes above towards the crown. directly above the IAC. And then take a look. It appears that it has a shorter distal root, and it also shows that it may have a lost white line of the IAC together with a darker root tip on the distal root. After careful removal in this case, the case showed a tooth that had notching, grooving on the distal root, and a completely separate meshobuccal and mesholingual root. Now, I would assume the IAC run in between these roots on the mesial part of the tooth or root. Fortunately, this was removed without any nerve dysfunction on the part of the patient. Remember that apart from the proper planning that you may have and the proper execution of your plan to reduce this inherent complication, it is as important to inform your patient beforehand of these possibilities. Inform the patient even your plan to mitigate it. An important thing to consider is that an explanation, even if it is correct, becomes an alibi when you say it after the complication has happened. Something to think about. Following this general idea of the inherent complication, these diagrams show a study from the 90s by Rude on the relationship of the third molar roots and the IAC as seen on the panoramic radiograph. This study said that the diversion of the canal, the darkening of the roots, loss of the white IAN line is significantly related to nerve injury and is considered to be the most reliable sign. The deflection of the roots, narrowing of the roots, on the other hand, is an important indicator to nerve injury, and in these cases, it may warrant further clinical evaluation. While the narrowing of the IAN canal and the dark bifid root apex does not show that it is a reliable indicator in terms of nerve damage of the IAN. Here is a cross-section of an actual case that demonstrates the relationship of the impacted tooth with the IAC on varying areas of the impacted tooth. Corollary to this complication, I had a webinar course conducted by Dr. Miloro on nerve injuries, and to share some of the insights in that lecture, it is consistent with most reports that the lingual nerve appear to be more commonly affected than the inferior alveolar nerve. Although the implication of the nerve damage to the IAN may be more significant to our patients, that's why there's a hype towards this complication associated with third molar removal. As for neurosensory testing, I found this modified cotton applicator very economical, and yet it can perform the brush directional testing, 2-point discrimination, contact detection, and the pain perceptions using pinprick and even temperature. This diagnostic algorithm shows most likely the degree of nerve damage from neuropraxia, axonotmesis, and the levels of neurotmesis. In this particular diagram, you would normally start testing from directional 2-point discrimination, so level A. If it's abnormal, then you proceed to contact detection, level B. If it's normal at level B, then it could be considered mildly impaired. If it's still abnormal, then you proceed to pain sensitivity testing, level C, damage. If after testing it appears to be normal, then it's considered to be moderately impaired. If it is abnormal, if the patient has no response, it's considered to be anesthetic. If response is an increase in threshold or a decrease in response, then it's considered to be severely impaired. In this particular cohort study, it reiterates that more patients suffer from lingual nerve damage compared to infioalveolar nerve damage associated with third molar surgery. For the lingual nerve damage, most of the neurosensory dysfunction is related to numbness and tingling sensation, while for the IAN damage, most of the dysfunction appeared related to numbness, tingling, pins and needles, hyperalgesia, and allodynia. This is an interesting retrospective cohort study on a traumatic neuropathy of the trigeminal nerve, looking at several procedures. Their data reported loss of sensitivity only with non-third molar impactions, implant placement, and local anesthesia, which so happens to produce the highest incidence for loss of sensation. As for mandibular third molar procedures, majority of the patients had symptoms or combination of symptoms not involving pain, like those tingling pins and needle sensation. Further data showed that most of the affected nerves presented with are all symptoms categorized in this study. However, mostly it showed symptoms not involving pain. Interesting to note that the maxillary nerve in this study presented with loss of sensitivity and symptoms associated with pain, but not the symptoms attributed to be painful. Another interesting table in this study showed that for implant placement, nerve injuries were always persistent. For mandibular third molar surgery, equal incidences of persistent and temporary nerve damage was seen. Only in local anesthesia, where there is a significant higher amount of temporary nerve damage, was shown. The authors summarized their findings and stated that the possibility of successful treatment is diminished by the late referral caused by delayed acknowledgement of an injury, limited knowledge of symptoms, diagnosis and treatment, consultation of multiple clinicians, and uncertainty regarding the optimal referral for different mechanisms of damage. Lastly, these are uncommon complications, but they do exist, and that would be fracture and displacement. Now, if you look at the keywords, fracture during third molar surgery in PubMed or other indexing modalities, you would see that the papers are replete with case studies, technical reviews regarding mandibular fractures following third molar surgery. Most of them would say that the mandibular angular fracture is a rare but very severe complication to mandibular third molar surgery. They do occur. One paper from the Australian Dental Journal listed risk and predisposing factors for angle fracture arising from mandibular third molar surgery. They've categorized it as patient factor and surgeon's factor. During the operation, patient factors would be age and gender, male that is more than 40 years of age, position and space of the third molar that it occupies, the degree of impaction, and presence of any local pathology or systemic disease that may impair bone strength. For surgeon's factor, not well-planned treatment, including the osteotomy and odontosections, would be an important consideration. Improper instrumentation is another factor, and the most common factor that would cause fracture is use of uncontrolled excessive force. After the operation, patient factors that may risk or predispose a patient to angular fractures would be gender, bruxism, preoperative infection of the third molar site, and patient's participation in contact sports. Last uncommon complication that may arise from removal is displacement of the impacted tooth to anatomical spaces. This is a case report of an accidental displacement of a mandibular third molar following its removal into the parapharyngeal space during extraction. Most often, displacement into anatomical spaces occur when improper flap has not been raised and when we perform what we call blind procedures, wherein we just simply use the instrument to displace the tooth without even looking at what we're doing. Now, we do agree that there are some areas that may not be as directly visible, but we never try to do things completely blindly. That is why one of the important aspects in managing impacted tooth, odontectomy, is the proper access. And that would be related to proper raising of a flap.